Hello, and welcome to the IBD School 800 series. My name is Leslie Aldrich, and I am an IBD specialist at the University of Michigan. In this video, IBD School 804, we will talk about pregnancy and IBD medications. If you haven't yet, please check out our other videos in the 800 series on fertility in IBD and breastfeeding in IBD. As a general rule, once you become pregnant, you should continue to take all of the medications you regularly would to treat the symptoms of your IBD. Nearly all medications associated with treatment of IBD have been shown to be safe for use during pregnancy. The exception is methotrexate because it is teratogenic, meaning that it can disturb the development of an embryo or fetus and lead to birth defects. It also increases the risk of fetal death, also known as spontaneous abortion. You should stop taking methotrexate at least 6 months prior to considering becoming pregnant. If you have already conceived while taking methotrexate, you should discuss your pregnancy very early on with your gastroenterologist in order to determine what is the best course of action. Another medication that is dangerous in pregnancy is thalidomide, which is famous for producing birth defects in babies. We never use this medication in young women who might get pregnant. When you are pregnant, it becomes even more important that you routinely take your IBD medications in order to keep symptoms to a minimum and prevent flares. Flare-ups can have a negative effect on your baby's well-being. The most successful pregnancy and birth outcomes for women with IBD are associated with good, stable disease control through use of medications, while women who experience active inflammation during their pregnancies tend to have higher risk pregnancies and higher risk birth outcomes, including preterm delivery and smaller than expected babies. If you do develop a flare while pregnant, your gastroenterologist will likely change your medications. Women with active disease have a higher risk of adverse pregnancy outcomes such as early delivery and low birth weight, so keeping the disease under control is important. If necessary, addition of steroids or anti-TNF therapy can be used to control inflammation to improve your health and the health of the baby. Keep in mind that changes in your medications might be made because of symptoms, but also as you near delivery. If you've generally had difficulty managing your IBD during your pregnancy, all of your IBD medications should be continued through your delivery, including medications that may have been added during pregnancy to deal with additional symptoms of your IBD. On the other hand, if your disease was in complete remission when you conceived and you have had a rather uneventful, healthy pregnancy, your physician may decide to stop some medications once you near delivery. They may choose to do so because some medications can cross the placenta and get into the baby's bloodstream. This means that as you near term, every dose of medication you take, the baby will also get, but at a much lower dose. Good news though, to date studies have not shown an increased risk of infection or developmental delays in the baby with the use of medications. In fact, one study showed that if mothers used anti-TNF therapy during pregnancy, babies were more likely to reach their 2-year milestones on time. This appears to be due to better control of inflammation during pregnancy. One downside of using anti-TNF medications through pregnancy is that your baby cannot have live vaccines in the first month of life until all the anti-TNF medications are out of their system. It is very important that your pediatrician knows if you were on an anti-TNF medication so that the MMR vaccine will be delayed until 6 months of age. So if you have biologic remission, a physician can have the luxury of deciding to stop medications when nearing the delivery, and they may choose to do so. Exactly when in the timeline of your pregnancy these medications are stopped will depend on the frequency of the medication you are taking, as well as your expected due date. In rare cases, if a patient's IBD is out of control once they near their delivery date, A physician may elect to deliver early by cesarean if the fetus has developed enough to be healthy upon delivery. In short, the healthier you are, the healthier your baby is. So stopping any IBD medications and risking a flare could risk your baby's health. Once you are approaching your due date, talk to your physician about whether your IBD medications should be continued depending on the state of your pregnancy and your IBD. I'm Leslie Aldrich, and thank you for watching IBD School.